One thing optometry has been missing is a unified message that explains the importance of eye care. Now, OIE Broadcasting has solved that dilemma. We are very excited to announce the first subscription-based monthly content delivery service that will not only enhance and expand your practice, but elevate the industry. Please visit oiebroadcasting.com and sign up today. That's oiebroadcasting.com. With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. Hello and welcome to the Open Your Eyes podcast. I'm Dr. Kerry Gelb, the host of the documentary Open Your Eyes. Please visit the film's website at openyoureyes2020.com, featuring interviews with more than 50 optometrists from around the country sharing information on eye care and eye disease. If you're new here and you like our interviews, press like, subscribe, share, and hit the bell to get notifications of great new interviews. Also, please leave comments. Glaucoma is a blinding but preventable group of diseases that cause damage to the optic nerve. Treating glaucoma successfully is a team effort between patient and doctor. Today's guest, Director of Optometric Services at Bascom Palmer Eye Institute, University of Miami Health System, optometric physician, Dr. Mark Dunbar. Dr. Dunbar is a fellow of the American Academy of Optometry and is a founding member of both the Optometric Glaucoma Society and the Optometric Retinal Society. Dr. Dunbar, thank you for joining me today.
Thank you, Kerry. It's great to be here. I know we've been looking at trying to do this for a while, so I'm glad it's kind of finally worked out.
It's great to be talking with one of the optometric all-stars. So I know you have a lot to offer and to offer our audience, and we have a lot of people in our audience who are not in the vision community, but are very interested in what we do. Probably about 20,000 people will watch this once we show it the first week or two. So let me ask you, what's new in glaucoma?
What's new in glaucoma? That's a loaded question, right? You know, there's a lot. Obviously, we're in an era of technology. So when you look at innovation, there's new drugs. There's technology in terms of being able to diagnose or recognize glaucoma earlier is now here. Just understanding fundamental principles. You know, why does glaucoma develop? Is it just related to intraocular pressure, or are there other variables involved in the diagnosis and etiology? Obviously, genetics is a hot topic, and I think we're really kind of scratching the surface on kind of understanding what are the genetic links. Unlike macular degeneration, where we really got kind of the genetics mapped out pretty good in terms of understanding pathophysiology, we know that glaucoma is really very much a heterogenetic disease. There's probably several or lots of different genes that predispose an individual from getting glaucoma. And again, I hope we don't talk about that, because I don't know much about the genetics other than it is kind of complex, and I think we're a little behind compared to other areas.
So somebody who's been treating glaucoma for many years and involved in the treatment of glaucoma, what has surprised you about treating glaucoma and glaucoma patients? Every once in a while, something, there's a eureka moment or something that may surprise you. I'll give you an example for myself. We were taught in school that, and excuse my New York accent, but we were taught in school that glaucoma, open angle glaucoma, and we'll talk about the different types, really has no symptoms and no pain. But I have found patients with glaucoma, open angle glaucoma, that do have pain. And it's not very common, but it does happen. What has surprised you over the years, and what have you really learned and that you really bring into it when you're examining a patient that may have glaucoma?
Well, I think first of all, the technology, the advances in technology has really helped us. So you and I are fairly close, right? So I remember when we graduated and started practicing in the 80s and into the 90s. You really had, looking at a nerve, checking a pressure, and obviously doing threshold visual fields. But, at that time, threshold visual fields were very difficult to do. They were long. It required a patient to be able to perform the test and be accurate at doing the tests. And we know that was not an easy option or easy task for patients to do. And so I think it was just difficulty sometimes being able to make a diagnosis of glaucoma, because as you know, it's complex. You can have somebody with elevated pressure who doesn't have glaucoma, has normal optic nerves. Of course, we call that ocular hypertension. And then, you can have somebody with a normal pressure, quote normal, because typically we kind of consider the normal range anywhere between 10 and 21. So you could have somebody at maybe a pressure of 15 or 16, and it can look like they've got very bad glaucoma. So, and then you have really everything in between, some suspicious nerves, a threshold or a borderline pressure. And you would see these patients and you're, they're sitting in your chair, you're kind of feel the pressure to make a decision. Is this glaucoma? Do I need to treat it? And a lot of times, that was not easy to be able to do. And then for the patient who had glaucoma, trying to follow them over time and make a decision, gosh, is this patient progressing? So looking longitudinally at visual fields when the patient wasn't great at doing visual fields. And we know that fields are prone to long-term fluctuations, meaning, sometimes they do well on the field. There's days where, they don't do well. And again, you're trying to put all that information together and making a decision. And I think it was really never easy to do. And for that reason, I think there was probably a lot of intimidation. Many ODs would send those patients to an ophthalmologist or glaucoma specialist just because, they didn't want that responsibility. So fast forward to where we are today, right? Where we've got better visual field algorithms. They're quick, they're highly sensitive, easier for patients to do. And then you've got OCT imaging, which again provides an objective means besides doing a visual field of helping determine, is this nerve abnormal? Is this patient progressing? And again, not just looking at a visual field, but looking at objective longitudinal information from an OCT. So for me, what's kind of been the epiphany, it's just, the marriage of technology and really just embracing, having these patients in your chair and being able to really, as an optometrist, provide the same level of care and service that an ophthalmologist or a glaucoma specialist would, right? Because they don't have any different information than you have. They're looking at the same data. They're looking at an OCT, a visual field, an optic nerve. And so I think it does give you confidence. So when you're making those decisions, is it glaucoma? Do I need to start treating? Or is this patient getting worse? It's leveled the playing field. And I think that's allowed optometry to more ODs to follow glaucoma, treat glaucoma. And so that's been the fun. And, when I'm in my lectures, we were just at Vision Expo this weekend and we were doing some glaucoma stuff. And that was really one of the discussions. How great is it that we have this technology that we're able to make educated decisions? Is this patient getting worse? Is this glaucoma? And again, even with the technology, it's not, one or two visits. I mean, I showed a great case of a patient who I've been following for 10 plus years, who's got really suspicious optic nerves, a family history of glaucoma. And again, the OCT imaging, because they were abnormal to begin with, wasn't a lot of help. So it took a long time to be able to kind of make a decision. Is it glaucoma or is it not? So again, I think it's part of your practice that I would really encourage all optometrists to embrace and really have fun with.
When you look at the studies, about 40% of the people that are treated for glaucoma actually go blind in one eye, even though they're being treated. But I believe those studies are old, because if you look at the current treatment of glaucoma now, because of what you're saying, we're able to diagnose glaucoma much earlier, just like with any disease. The earlier you diagnose a disease, the better, and the better the outcome. So that's why it's so important that patients are getting their eyes examined and that they're being checked to see if they're at risk for glaucoma. But early treatment is really the key to preventing blindness. And I think that 40% statistic that you will go blind in one eye if you have glaucoma no longer really applies, because we're finding glaucoma so much earlier with this great technology that we have.
Correct. No, I think that's absolutely right. And I don't know how accurate those numbers are either. What I tell my patients and what I tell, when I'm lecturing to colleagues on the podium, when patients get into trouble. So when you're looking at those patients who are going blind or lose significant vision loss, it's it's really one of two reasons. It's one, it was diagnosed very late. So to your point, Carrie, patients for whatever reason aren't coming in. So you think of the emmetrope who sees well, they're relying on over-the-counter readers, and they don't really understand the reason why they need to come in to get an eye exam. And so, those patients who think they're doing well, or, they've got a pair of glasses that have worked for years. And so when they come in, they've already got advanced disease. And so that becomes more difficult, to your point. As the more advanced the disease is, it gets harder to be able to effectively manage. And again, sometimes you require surgery, laser, and those type of things. And then the second group is the patients who just don't comply. This is the same probably group of people who, not the same, but we see patients who have poorly controlled blood pressure, patients with diabetes who don't control their blood sugar. And again, it's just, poor recognition of a problem, because to your point, glaucoma for the most part is asymptomatic. And until it's very advanced and robs your central vision, many patients are unaware. And so, they see their eye care provider and are told they have a disease, and they have to, it's like believing in a higher God. It's faith, right? Do I trust and believe this is to be true, and that I'm going to have to take an eye drop when I feel perfectly fine, my vision is perfectly fine? Why do I need to take a drop, right? So when patients have trouble, it's compliance. And so then it goes back to, the job of the eye care provider of helping patients so they understand their disease, and really the importance of why we're taking this drop. And so whether it's showing pictures, letting them see their visual field, et cetera. And again, that's why I think optometry is uniquely qualified to handle it, because, we're not like a glaucoma surgeon who may have 50, 60, 70 plus patients in a day. And how can they really dedicate the kind of time that sometimes some patients need to be told about a disease that, and that's the difficulty. So I think the one thing optometrist does really well is we spend time, we understand our patients. Many times we've followed them or their family members for years. And so we do often have that inherent trust and have the ability to really help explain. And again, sometimes it's, takes a couple of visits and saying it a few different ways for patients to really finally kind of get it and understand, that they've got a disease that requires lifelong, treatment.
And there's about 3 million people that have glaucoma, and another 3 million that don't know that they have glaucoma. And there's a lot of people who are at risk for glaucoma. They'll come in, their pressure is borderline, and they have to be followed. So glaucoma is the third leading cause of blindness worldwide, but the number one leading cause of preventable blindness worldwide. So glaucoma is a very elusive condition, and it's not something that you could be examined for by telemedicine.
Well, correct. You're right. I realized I didn't answer your question about, pain, right? So to your point, many patients with glaucoma are asymptomatic, don't have any pain. And the only time they will have pain is if, because we always get, we all can relate to this, right? The patient who comes in and says, I feel like there's a pressure in my eye. And we kind of try to figure out, well, what does that mean? Because you measure the pressure in the eye and it's normal. And so is there a direct relationship or correlation to this? Boy, I feel like pressure in my eye. And typically not. I often kind of attribute that to maybe dry eye or just non-specific inflammation. But you're right. I mean, you can have very high pressure and not have any pain or any symptoms. So you're right. It becomes difficult to how do you make a diagnosis? And if we're using checking a pressure, which may be normal, and we know that maybe a third or 40% of patients can have glaucoma at a normal pressure, and then looking at an optic nerve and trying to put those two things together. And we know that there's a large variation of normal among different populations. The African-American populations can have bigger nerves and bigger cups. And so unless you look at them, so to your point, Carrie, I mean, how do you make that diagnosis via telemedicine format? And I don't think you can. I mean, that's a technology that at Bascom Palmer we're doing a lot with. We're exploring a lot of different ways to utilize telemedicine, so ways patients don't have to come in the office. But and we are actually exploring how to do that in a glaucoma setting. So, but that excuse me, that's maybe a patient who thinks they have glaucoma, or they're calling up saying, I was told I have glaucoma. And so how we're handling that is we may kind of develop an image, a telemedicine imaging program, if you will. So patients may come on a Saturday or at a time where the clinic is less busy, get all their imaging done. They get an OCT, they get a visual field, maybe they get a pressure check by a technician before they ever come and see an eye care provider, see the eye doctor, and then you can maybe connect remotely looking at all the data. And that would be probably the only way in a telemedicine format that you could, make a diagnosis or really see that a patient has a suspicion of glaucoma.
And there'll be a day where a patient will be able to wear a contact lens that will take their eye pressure.
Well, exactly. And that actually exists, right? We're there, and even OCTs, right? Notal is a Israeli company that has developed a take-home OCT device. I mean, you think about that, right? And it's small enough that patients can take it home, and that's used mainly to follow patients with macular degeneration and probably diabetic retinopathy. But it's just, it speaks to technology and innovations in technology where, yeah, you'll be able to measure a pressure remotely, or they'll be able to take an OCT home, and boy, and I hate to bring this up, but I will, just because we're talking about glaucoma. I was at Vision Expo, and one of the companies that was there is a company called Hero, Heru. Now, they have using the kind of the Oculus type device, this virtual reality type. So they've developed this very sensitive and sophisticated visual field machine. So no longer are you going to have to, go into an office and this device that takes up a lot of space like an egg. You'll be able to, even in a waiting room, or maybe even send it to a patient where a really highly sensitive and specific device that will perform a visual field in a matter of minutes. And again, much easier for patients to do, really kind of changes the game from how you and I, and even today, our patients are doing visual fields. And again, this is just one of the companies. And let me just kind of qualify that. This is developed at Bascom Palmer, and I'm part of Bascom Palmer, so I'm not trying to sell it or tell you theirs is any better. I just happened to see them at Vision Expo West and was surprised how far along the technology has gone. But as I said, there's others where, these will be able to, send patients information, or things to be able, whether it's an OCT or a visual field. So they will be able to kind of do some of these tasks remotely, not in an office. And I think that would be a big help. Again, especially maybe more relevant to busy academic referral or ophthalmology, centers where you've got large volumes of patients.
Doing visual fields on an iPad or VR. I mean, there's a number of companies working on it. They're working on it at Stanford, and All Eyes has one. And you have the glaucoma researchers have been trying to figure out the cause of glaucoma for 100 years. Do you have a preference at Bascom Palmer? What do you guys think is the cause of glaucoma? Where do you guys lean?
We're still kind of meat and potatoes. I mean, like everybody, right? You check a pressure, and then you can't help but think, well, what does a pressure in the anterior chamber have to do with glaucomatous optic nerve damage? And so, and it's been thrown around forever and ever. What are the causes? Is it perfusion pressure? And we've all seen the patient who's thin and frail and is probably on a blood pressure medication, and what may happen is at night they get these nocturnal blood pressure dips, and that combination with increased intraocular pressure, because we know pressure is highest right before you wake. And so it's that combination of low blood pressure, high intraocular pressure really kind of affects perfusion pressure. But how do you measure that, right? We're checking blood pressure on the arm. And again, the same thing. There's really no standardized method of looking at what perfusion pressure is. I think maybe even more relevant, and this is work that John Berdal has done. John is when he was I think a fellow at Mayo Clinic in Rochester. He looked at, essentially gets down to cerebral spinal fluid pressure, right? Because you look at the optic nerve and cerebral spinal fluid, or at the level of the lamina, that may have the most influence. So when he was at Mayo, one of his studies was he looked at, I think, 10,000 plus patients who had lumbar punctures. And then of those 10,000, he looked at the number of patients who actually had eye exams. And then of those who had lumbar punctures and eye exam, which percentage had glaucoma? And what he was able to show was patients with glaucoma had low cerebrospinal fluid pressure. So it's kind of becomes a little bit of a physics problem, right? You have high intraocular pressure, so high pressure in the eye, low cerebrospinal fluid pressure, so about near the lamina, it's that pressure in the eye that's causing damage because of low cerebrospinal fluid. He repeated the study first study had 20,000, the next 10,000, the next group I think had over 20,000, and really found essentially the same thing. So again, whether it's perfusion pressure or low cerebrospinal fluid pressure, I think, or, just your body's ability to kind of adapt to various, whether you're laying down or cold weather or whatever the facts is, your ability to auto-regulate. But I think more and more data really is a link between, probably low cerebrospinal fluid pressure and that being maybe one of the main contributory causes. So one of the questions that, again, somebody who doesn't have high pressure glaucoma, have you ever had a cerebrospinal fluid leak? Have you ever had, spinal surgery or maybe some type of motor vehicle? You start asking those questions, trying to maybe understand, are there other things besides traditional intraocular pressure that may play a role? And
now, one time it was big to look at the blood pressure, systolic, diastolic,
Yep.
if it was very low, and there was a formula to see if you're at greater risk for glaucoma or progressing, your glaucoma progressing. Are you still using that, or would you say that's fallen out of favor?
No, I don't think it's fallen out of favor. I think every kind of major population study have really shown a strong link or correlation between low perfusion pressure and glaucoma. The Barbados Eye Study, the Latino Eye Study, there's, several others that I'm probably forgetting, all show this 3, 4, 5-fold increased risk of glaucoma with low perfusion pressure. And so, there is a complicated formula, but the simple formula is taking the diastolic blood pressure minus the intraocular pressure. And so I think the number is anywhere between 50 or 55 is kind of considered maybe somebody who's at risk. And so, no, I don't do that on every patient, but I do have, many patients with what appears to be normal pressure. I have a case that I just think is really fascinating, and I have it together. I show it in a lecture. It's a lady who's pressure 15, 16, right? And when I first saw her, she had a disc hemorrhage. And so, and she had abnormal OCTs and abnormal visual fields, and we put her on a glaucoma medication, a prostaglandin, and we followed her. A year later, I see her and her pressures are 12, and now she's got a disc hemorrhage in both eyes. And so, if we think of glaucoma as a pressure disease, how is it that here's this little old lady who's got pressures of 12, so low, and yet she can still have glaucomatous damage in the form of a disc hemorrhage? And so this is, almost you look at, well, what are other factors? And she may be the poster child for low perfusion pressure. She's always cold. She's frail. And so, I think you look at those type of instances and it's fair to, all right, what blood pressure medications are you on? Maybe you communicate with her primary care physician and, is she on a beta blocker, or is she, is her blood pressure maybe at night too low? And that kind of fits that description of what we were just talking about, where they've got low perfusion pressure at night. And so she may be fine, 22 hours of the day, but 2 hours of the day, she's got these, this low blood pressure and maybe a little bit higher intraocular pressure that, which is, again, perfusion pressure. So no, I think it's still relevant. I just don't think we have a good standardized way of measuring it like we measure intraocular pressure on a patient every single time they come into our office.
Now, if she had very low blood pressure, wasn't on any medication, would you consider doing things to help raise her blood pressure?
I wouldn't, and that actually has been thrown out to you, prescribe Lay's potato chips, twice a day to, something high in sodium to get their blood pressure up. And though that may sound reasonable, I think, the scientists, the investigators haven't gotten to that point where they would, recommend doing something like that. But I actually did read an editorial about just that very same thing. So
one thing optometry has been missing is a unified message that explains the importance of eye care. Now, OIE Broadcasting has solved that dilemma. We are very excited to announce the first subscription-based monthly content delivery service that will not only enhance and expand your practice, but elevate the industry. Please visit oiebroadcasting.com and sign up today. That's oiebroadcasting.com.
Yeah.
Let's talk about risk factors for glaucoma. Go over some of the risk factors, and there's some obvious ones and some ones that aren't so obvious. So if you could talk about those.
Family history probably being, a significant risk factor. We always look at that, when a patient says, my father went blind from glaucoma, and you're looking at a patient who's got a suspicious nerve and a borderline pressure, right? You're like, oh, well, that probably means a lot. And maybe that patient is at greater risk. Now, ideally, you would love to be able to do genetic testing to know really what that patient's genetic risk is. But, I don't think in 2021, we're at that point where we're able to make that jump. Obviously corneal thickness has been borne out as being a significant risk factor. So if you have a thin cornea, that really puts you at a significantly higher risk. And that was again borne out of the ocular hypertensive treatment study that was done in the 1990s. And so, much like checking an intraocular pressure, measuring, corneal thickness has become really, I think, the standard of care when you're making a decision, is it glaucoma, and treating glaucoma. So, and again, for those who aren't, eye care providers or listening, when we measure the pressure with our device, it's predicated on the cornea being a certain thickness, an average thickness. But what happens when you have somebody who has a thinner cornea than average, or somebody whose cornea is thicker than average? And again, if this measurement that we're getting is based on an average thickness, we recognize that may not be the true pressure. So if you have a thin cornea, you may be measuring the pressure lower, but it actually may in fact be higher than that. And likewise, a thicker cornea, we may be measuring it higher, but it may indeed be lower. So even though we don't make that, we don't kind of write down what the true pressure is, we just look at it as a risk factor. Somebody who has a thinner cornea, we say, boy, I know the pressure, what I'm measuring probably is higher than what it is, and that is a significant risk factor. And so, that being, I think, one of the, obviously more significant risk factors for glaucoma. Obviously, the higher the pressure is, the greater the risk of glaucoma. The larger the cup is a greater risk for glaucoma. High myopes or myopes certainly is a risk factor, but I don't think we put that at maybe the same risk factor as somebody who's got thinner corneas, for example.
And just to reference, a high myope is someone who's very nearsighted, and the cornea, this for people watching that aren't in the eye care community, is the front of the eye.
I would say it's like the crystal on a watch, right? So we measure the pressure like we measure the air in a tire, but we measure it looking, indenting the crystal on a watch. And again, that's based on, as we just talked about, an average thickness, but not everybody is quote average.
And how about hypertension? That kind of goes back and forth, but when somebody has hypertension, they have increased sympathetic tone, that sometimes their natural serum, their corticosteroids in their blood actually go up in their serum. And that could actually raise the eye pressure. How do you feel? I've been seeing patients for so long, and I feel that, we always talk about hypertension being related to higher intraocular pressure or increased risk of glaucoma. But quite frankly, I don't think it's that big of
No.
I don't think it really matters that much, to be honest. But what do you think?
Well, so, and that's, of course, when you talk to a patient about glaucoma and that their eye pressure may be too high, they automatically make that correlation between eye pressure and systemic blood pressure. But I would agree with you. And again, think of it, the discussion we just had with perfusion pressure, right? I think if anything, higher blood pressure may be more protective, because remember, low blood pressure affects the blood supply getting into the optic nerve. So it's really the lower blood pressure that I think is really more concerning than higher blood pressure. Now, again,
Exactly.
It's all relative. We're not talking malignant hypertension where, you're at risk
Sure.
of a stroke, but a little bit of high blood pressure, or the average patient who has blood pressure and is on a blood pressure medication, I don't think that adds any risk. And if anything, the blood pressure maybe I hate to use the word protective, but to your point, Carrie, probably doesn't really affect it in any way. It's not a significant risk factor, or even a risk factor, I don't think.
We talked about perfusion before. How about sleep apnea?
Yeah, that has really come up over the last 10 or 15 or 20 years. And again, sleep apnea affects so many things, right? And we're just now, I think, scratching the surface and even not even understanding, just recognizing that sleep patterns and sleep apnea, there's so many diseases, whether it's central serous, whether it's diabetes and macular degeneration, but certainly glaucoma, it plays a role. And so if again, you're looking at everything, and sometimes it's not at the top of your radar, but for the person who seems to be progressing, or you're looking at normal pressures and you're not really understanding why this patient has glaucoma advancing. I mean, yeah, do you have sleep apnea? Do you snore? And many patients, especially now in this age where they've done sleep testing and those type of things, or I think it's a little more on people's radar. So yeah, it may be contributory, possibly is contributory. I will recommend sleep studies to patients if they haven't, or if they think, they have a partner and what does your husband, wife say about your sleep patterns, et cetera. You may want to, get a sleep study to, let's see if sleep apnea is, if you have it, and then we can kind of look and try to decide, do we think that's playing a role? But again, it's become a hot topic, and I'm not really 100% familiar with any direct studies that have been done, but it comes up over and over among our colleagues that and glaucoma researchers, where you've got to ask the question, and again, you maybe need to recommend sleep studies to patients to determine if they have sleep apnea.
There's been studies that show up to 70% of people with migraines have an increased risk of glaucoma or elevated pressure. What do you think about that?
I haven't looked too deep into that. I don't know. I guess theoretically it's a risk factor. I just, it may be further down on the list for me. I typically don't, I don't really explore that, and that may be an area that I probably need to look at more carefully and find out. Certainly we have lots and lots of patients who suffer from migraine. I have family members who suffer from migraine and who don't develop glaucoma. So you just wonder, is it that, because there's so many people who have it, what is that cause and effect? It's like, retinal vein occlusions, right? Half the people have attributed to high blood pressure and the other half isn't. So is it just that it's so common that people with high blood pressure happen to have retinal vein occlusions? If that's the case, then I'd explain the ones who have retinal vein occlusions and don't have high blood pressure. And I would kind of wonder the same thing about migraine headaches. So it certainly could be a attributing factor, but I don't know too much about it.
People with a big belly and the metabolic syndrome tend to run high pressure, borderline high pressure. A lot of times you'll see them in the low 20s. And, there's been some theories of, inflammation, because metabolic syndrome causes inflammation. Inflammation is a core component of chronic disease, and the trabecular meshwork could have inflammation, maybe clog the drainage a little bit, or there's sympathetic hyperactivation going on there. Do you have a feeling about metabolic syndrome and its relationship to to elevated eye pressure?
I don't. And you may well be correct in everything you say. I think I get more concerned with metabolic syndrome in the context of patients with diabetes. And it's really, to your point, that combination of diabetes and metabolic syndrome really, becomes a significant risk factor for cardiovascular disease and death. I mean, you can have diabetes and, controlled diabetes and no metabolic syndrome, and your risk is very, very low, almost the same risk as somebody who doesn't have diabetes. But you throw metabolic syndrome in there and diabetes, it becomes a formula for, really catastrophe. So metabolic syndrome is really a big deal. I haven't, as I said, I haven't explored it in glaucoma, but it would make sense just because overall body health, well-being, oxidative stress, etc. I mean, it would make perfect sense to me, but but I'm not aware of any direct relationships or correlations. So
a lot of patients, as they advance in glaucoma, they'll have trouble reading, maybe driving. What kind of advice can you give to these patients?
well, it's a good one, right? Because there's no question patients who have significant visual field loss, or almost any visual field loss, are at greater risk of falls and accidents and those type of things. So again, it kind of goes back to your kind of our earlier discussion regarding the number of patients who go blind and lose vision. I tell patients, we've got 20-year data from the ocular hypertension study, right? Where these are patients who didn't have glaucoma that were at risk. They had high pressures, they had normal fields and normal optic nerves. And one group got treated, one group got followed, because the question was, does treatment lower the risk of progression? And yes, there was a benefit of treatment, right? So, but even those patients who weren't treated, many of them did develop glaucoma. But here's the long and short of that, right? So 20 years later, glaucoma developed in about a third of eyes, meaning 2/3 of people didn't develop glaucoma. And so one of the conclusions was glaucoma, at least in ocular hypertension, is largely, unilateral. So, many of them, some of them did develop it in both eyes, but the point was many of them only had it in one eye. So, to answer your question, Carrie, glaucoma tends to be asymmetric. Patients can have significant vision loss in one eye and maybe they're normal or, not sight threatening or life functioning vision loss. But even in those instances, yes, there is a greater risk, but I would say in terms of quality of life, being able to recognize a face, read and drive, right? I try to be encouraging to patients. Again, we follow you. We're going to see you twice a year, maybe 3 times a year. You take this drop, even though there's, vision loss, significant vision loss in this eye, with the other, between the two eyes, this shouldn't really have much of a significant impact on the quality of your life. So yes, I think the risk is there. And again, that may be part of the discussion on why you need to take a drop and why we need to kind of continue to watch you, twice a year, 3 times a year, depending on how severe their glaucoma is. But yeah, I mean, I try to paint a picture. I mean, I certainly have patients where you do have to talk about, severe vision loss where they're not, they're really not able to drive a car. They're driving a car, but you tell them you don't meet, in the state of Florida, you don't meet the Florida requirements to drive a car. And so I'm going to have to tell you that you shouldn't be driving. You don't meet the requirements. So yeah, I mean, it certainly is there. I think part of our role as primary eye care providers is counseling patients, helping them understand, recognizing, when there is vision loss and when it certainly could be significant, where it puts patients at a higher risk.
What we found with people, they still meet the criteria for driving, but like yellow or amber tinted lenses seem to help a little bit with reading. Sometimes reverse polarity in the letters, using a white letter on a black background sometimes helps. Of course, the easy things of just magnification and things. But, it gets tricky because as the glaucoma progresses, even though one eye, as you said, is asymmetric, it is kind of like a loss of power, so to speak. So before it starts, you could see at a power of 10. And as you're starting to lose some of the fibers in one eye, the power goes down, even though you could still goes down to maybe a 7 or a 6, but you can still pass the test, so you could still drive, but the contrast may not be there. So sometimes these little tricks could actually help people.
Well, and then taking a step back and looking at where the visual field defect is, whether it's a superior arcuate or inferior arcuate and those type of things. And so even though they may, to your point, might meet the law to be able to drive, certainly, depending on where the visual field defects are, can have a significant impact. And so recognizing it, and again, even having some of those discussions, showing them where they are, where they're missing vision, and how that may impact their ability to drive or see a stop sign or recognize, stop lights and those type of things.
How about different medication that increase risk? We get a lot of questions about medication. Sometimes the patients are coming and they're put on a certain medication that may dilate the pupil, and they'll say, can I take this medication? And the patients don't understand the difference between open angle glaucoma and narrow angle glaucoma. But talk about medications before we get into the types of glaucoma.
Well, the main medication for me that is a risk factor, of course, is steroids, right? And whether it's a topical steroid in the form of an eye drop, a steroid that might be an inhaler, less of creams and ointments, but steroids really increase a person's risk of having increased intraocular pressure. And you think of where we are today with dry eye, it's easy to put somebody on a loteprednol or a low dose steroid, and certainly I think the steroids work very well, but these patients cannot be left to just take a drop without being seen. There needs to be oversight because of that. So yeah, I mean, the steroid is the one that I really worry most about. And again, maybe they had ophthalmic surgery, or there's a long list of reasons why people are on steroids. And then there are certainly some drops that can kind of dilate your pupils, and those would be kind of the sympathomimetics. So patients that are on, some of the drops will dilate the pupil. I'm just blanking out on.
If they're on a decongestant, sometimes
the decongestant. Those ones.
Or they're on the bladder medication.
Yeah.
And they'll be sent in because they may cause the pupil to dilate a little bit. And, it's interesting because, that's why you really have to know the different type of glaucoma. Let me just pivot back to the steroids for a second, because that's really interesting when it comes to like people with asthma, and they're using right. The Symbicort, the Flovents, the inhalers. And what have you found with people on inhaler steroids for asthma and glaucoma and even cataracts?
Well, as we just talked about, it's a risk factor, and I think it's less of a risk factor for inhalers. But again, in the context of somebody who comes in who may have elevated intraocular pressure, you just kind of wonder what that correlation is. Again, in those type of patients, it's actually more central serous, and central serous is a condition that affects the retina, and the whole reason people get it is because of increased levels of cortisol. And if the retina, you think of like a ham and cheese sandwich, right? A lot of different layers. What happens when there's increased levels of cortisol, you can get fluid underneath the retina, and that can affect the central vision. So there's more indirect effects from those, the inhalers, the steroids, even I had a rash and I'm using a steroid ointment, anything that can increase cortisol levels in the blood can contribute and cause central serous. And I've had really many patients in that setting, whether it's through asthma, whether it's through sarcoid, where that has become more of an issue, right? They need the inhalers to be able to survive, to be able to breathe. And so you can't stop it, yet it can have a negative effect on the eye. So I think with IOP, it's more, as I said, nasal sprays and eye drops become really a little more of a threat, I think. But again, it's certainly is there. And then the long-term effect, as you alluded to, Carrie, is really steroids, and we see patients, the rheumatoid patients, the lupus patients who are on chronic steroids for medical conditions, they often will develop PSC cataracts. And again, in the era we're in, that's not such a big deal, because modern cataract surgery now is not trivial by any means, but with a good surgeon, it's 8-9 minutes an eye. There's no stitches. The eye doesn't get red, and the outcomes are very, very good. So, we worry a little less about PSC cataracts than what we used to. But yeah, the eye pressure thing is something just to be cognizant of and be aware of, and follow patients accordingly.
Yeah, I think the bottom line is if you are on a nasal spray, people think it's pretty innocuous, but you really need to get your eyes examined because you
Yep.
can get cataracts, you can get glaucoma from that. You brought up central serous before. Uh, at Bascom, are you guys using spironolactone for central serous?
We are. Yeah,
Mhm.
for chronic cases, for cases that, you know, in most patients with this condition, central serous, it gets better on its own. And just again, for those that are not, you know, eye care providers are familiar, it's more common in males. That 30 to 50 tends to be type A. And again, people who don't deal with stress well, your body tends to create more cortisol. Um, and when we have that discussion, just the fact that they have stress, or you ask them about stress, they get stressed about it, right? That's kind of the nature of these type A people. But in most people, it does get better. In many patients, it doesn't. So you look at how do you treat it if it's not going to get better. Sometimes if you can identify where a leak is, you can laser it. Sometimes we still do photodynamic therapy, which is again a kind of a cold laser treatment. But spironolactone, which is a high blood pressure medication, we will use on patients again who are more recalcitrant, aren't getting better, and it seems to work pretty well.
Yeah, I've had a couple patients that the central serous was chronic and we use spironolactone and we've actually had some good success.
Yeah.
So that's why I bring it up. So let's talk about the different types of glaucoma. Let's start with open angle glaucoma.
Yeah. So, and that's a hard thing to help patients really understand it. And I always kind of use the water faucet sink drainage analogy, right? That there's a fluid that gets produced in your eye, and there's a drain, and it drains out in the normal circumstance, it drains out at essentially the same rate that it gets produced. So this equilibrium is produced, right? There's a range of pressure, but the pressures is normal, quote normal, for them. We don't see optic nerve damage, visual function is not affected. And so what can happen if maybe the drain gets a little clogged, or maybe the drain is working okay, but the fluid, the aqueous, is being produced faster than it can drain out. And in that circumstance, the eye pressure can go up. And again, whether we think it's just direct eye pressure, or is it this correlation between cerebral spinal fluid pressure, perfusion pressure, whatever the case may be, damage is done to the optic nerve. And so we can treat these with eye drops, and there's many different types of eye drops now. And essentially what they do is they will facilitate, increase the outflow, or they may make it so, like a beta blocker, so you're not producing the aqueous or the fluid fast enough. So again, you're able to kind of keep and maintain that pressure. And so that's kind of traditional garden variety primary open angle glaucoma. And in this country, and the United States and Europe, that's probably the most common form of glaucoma there is. But that's not the case around the world. In some of the Asian countries, Angola, etc., just because of anatomy and the shape of their eye, that drain may be inherently narrowed. So the fluid may not drain. It may not be allowed to drain, normally. And so, you talked about, Carrie, things that cause the pupil to dilate, whether it's just, going into a dark room, or you're watching a movie, or you're driving at night. We know that the pupil will change shape based on lighting circumstances. So if you have an individual an Asian, who's maybe their corneas are a little bit flatter, or they're just, the shape of their eye is uniquely different, they are prone to developing a type of glaucoma called angle closure, and where the drainage angle becomes a little bit crowded, again, because of the shape of the eye. So you look at factors like aging, where the natural lens tends to thicken. You look at dynamics of the pupil that we just talked about. And interestingly, in those countries, it's angle closure is the number one cause of glaucoma, and not primary open angle glaucoma. And again, we see it here in the United States. We just don't really see it like they see it in other places around the world, which is quite interesting to me. And so Go ahead.
Sorry, so open angle glaucoma, the fluid is draining through the eye, bathing the eye, and there's a clear path for the fluid to get out, but there's a defect in the drain for whatever the reason. When we're talking about chronic angle closure or angle closure, the iris somehow is blocking where the fluid is trying to come out. So, and then the treatment would be different for these two. So if you could talk about how the treatment may be different for the chronic angle closure and the angle closure type, as opposed to the, we established open angle, generally we're going to start with drops, but with the chronic angle closure, we may have a different way of treating it. If you could explain that.
Well, so correct, right? So you talked about the iris being bowed forward. So the fluid is produced kind of behind the iris, between the lens and the iris, and it goes through your pupil. And so if you have, because of genetic variant, your lens begins to thicken. So what we'll sometimes do is we'll do a laser. We'll put a little hole in the iris, and that allows kind of the iris to come back, and it kind of maintains that fluid is able to drain out. It's able to maintain that kind of homeostasis, if you will. And so interestingly, that's become kind of the treatment of choice for either narrowed angles or patients who have chronic angle closure glaucoma. You put a little hole in the iris, and that kind of allows the iris to come back, and an equilibrium is maintained. That works if you're able to catch that patient early before they've developed, because over time, if that doesn't get recognized, you can get scarring in the angle. And even if you do a laser, once you've developed scarring, that's really not going to work. And so interestingly, what we're, maybe thinking about or discovering that even laser doesn't always work well in many patients. So as it turns out, cataract surgery really may be a better option. If you take the cataract lens out and put a lens implant, that may be probably the best definitive treatment for either narrow angles or angle closure or chronic angle closure. And again, that's still, kind of being researched and being embraced. It's not widespread done because a laser is certainly easier to do. And I think we're doing more laser peripheral iridotomies or iridectomies than we are cataract surgery, but that's really being looked at as an option.
Right. And with a young person that doesn't have the cataract, obviously, that's not, cataract surgery is really not an option at that point.
Well, but that really becomes the question, if this turns out to be a better treatment than a laser, that's being looked at. Maybe cataract surgery is still a better option, clear lens extraction. But you're right, that's where it gets kind of tricky. Yes, if you have a cataract, then it makes sense.
Even in a 20 or a 30-year-old, and then they lose their accommodation, it wouldn't be just to put the hole in. Well,
you don't see many 20 or 30-year-olds have that narrow angles that need laser peripheral iridotomies. It's usually that 50, 60-year-old, right, where you maybe have a little lens change. I think we can identify narrow angles, in those patients who are younger, but typically, they're not narrow enough where they're going to need to do a laser peripheral iridotomy. So
that's a good point. I just said last week I had a young Asian American female who was in her early 30s that needed that had chronic angle closure, that needed an iridotomy. So maybe that was top of mind.
Yeah.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
Since I bought Safe For You, my dad makes me clean his boat.
Es natural y es un buen producto.
Every time I go back to school, my mom always makes sure that I have my Safe For You products. I bring extra, and my roommates certainly don't mind.
It's a good thing I had Safe For You to clean up after this little guy.
When my hands get dry, I like to wash them with Safe For You.
And most importantly, the reason why I buy Safe For You is because it's safe for me and you.